Welcome to the Plastic Fantastic podcast, brought to you by Mr Adrian Richards and myself, Alison Telfer. Adrian is one of the UK's most experienced and eminent plastic surgeons specialising in cosmetic breast procedures. Myself, I specialise in all things to do with cosmetic non-surgical procedures. Each week, Adrian and I will be entertaining, interrogating, laughing and chatting with a whole series of guests. Anyone really who is fantastic and either works within or has been touched by our industry. And today, I'll hand over to Adrian.
So Alison and I are absolutely delighted to welcome the legend in the plastic surgical industry, that is Mr. Patrick Mallucci, aren't we?
I feel like we should do a round of applause at this point.
Well, I would expect no lesser introduction, Adrian. Thank you very much.
So just a bit of background now before we go on. So Patrick and I know each other from many years ago. Although Patrick looks 10 years younger than me, we're roughly the same age and have gone through the same training. But I've obviously had a lot more serious life events than Patrick. But Alison's going to be asking most of the questions to Patrick. So off you go, Al.
Thanks, Adrian. And the reason I am is because I'm sure, like a lot of our listeners and a lot of people who have sort of been here before, is that I've heard of Mallucci and Patrick Mallucci, but I've never actually spoken to you in person. So I'm delighted, Patrick.
It was lovely to be here. Thank you for the invite.
When I asked Adrian before, I said, how would you describe Patrick? Because I see this persona. How would you describe him? And he said, good-looking tick, clever tick, athletic tick, successful tick, therefore annoying, because he's all of those things. Now, Patrick, you're really...
I'm sorry to disappoint you, Alison.
Oh, no. So, you're really well known for your boobs and breasts, I guess. And so, whilst doing a little bit of research into you, I saw that you've done studies on what makes a beautiful breast. How did all this start?
Yeah, I mean, it's an interesting story, which probably it all started probably about 10 years ago, actually, and at the time, and Adrian will remember well, on a Tuesday evening at the Royal Society of Medicine, I think it was once a month or a couple of times a month, there used to be a teaching night for the trainees, the junior surgeons. And as consultants, we were often asked to give talks as part of that teaching program. And somebody rang me up and said, oh, I wonder if you could give a talk on breast augmentation. And I thought, okay, it's fine. And I was thinking to myself, what can I impart?
Pat, it was a day before, you hadn't prepared it.
Well, yes, it was. Last minute is something a little bit, ingrained in my lifestyle. So yes, I had let time go. I thought, oh look, I'll just Google a few things the night before and I'll be fine. And I actually thought, well, look, I'm gonna teach the trainees about the fundamentals of breast beauty. It's been done for the face. Leonardo da Vinci started it. It's been done for nasal proportion and measurements. And I thought, well, look, I'm going to go and see what's been written in the literature and I'll present that to the trainees. Lo and behold, nothing in the literature, which really flabbergasted me. It really surprised me. I thought, it's impossible. Something like the breast hasn't actually been analysed and measured, etc., etc. So I started to panic a bit because it was the next day. And I hadn't prepared anything yet. So I thought, what am I going to do? Now, the bit I can't remember exactly why. What I then did is I went to the page 3 website, and I know it sounds, a bit strange, a bit funny, but I knew 2 things about page 3.
And Patrick, just for our international colleagues, what is the page 3 and how much part of English culture is it?
Yeah, so the page 3, and I talk about this in lectures internationally, because you're right, our international colleagues are intrigued by page 3. The idea that a national newspaper on the 3rd page every day has a topless model is very bizarre for most people outside of the UK, but that's fact until very recently.
And Pat, they have to be natural, don't they?
Yeah. Right? So the deal is that there was a panel, an editorial panel, who selected these girls because they had attractive breasts, and the breasts had to be natural. So I thought, okay, as a pool of cases, that's not a bad start. So I thought to myself, look, let me have a look at 10 images very quickly to see if I can spot a pattern. And immediately, when I saw those 10 images, I spotted 4 features which were consistent and repeated themselves over and over. And I saw this pattern immediately. I thought, well, look, let's not stop at 10. Let's look at 100 images. Very difficult research, you might appreciate. I looked at 100 images, and lo and behold, these 4 parameters, express themselves over and over again. So at that point, I thought, there's something in this. And those 4 features, I'll tell you very quickly, are if you look at the silhouette of a breast, the outline of a breast, and you look at the amount of volume of the breast above the nipple and below the nipple, there's always a little bit more below the nipple than there is above it. And when that happens, as a consequence of that, what happens is that the nipple tilts upwards. So a skyward pointing nipple, a little bit more volume below than above the nipple, are 2 key features. And this is what was called what we term the 45-55 ratio. 45% of the breast is above the nipple and 55% below.
Pat,
fundamental observation. Yeah.
What, do you mean volume or do you mean distance?
Well, they equate to the same thing. They equate to the same thing. We measure distance, which is also equates to volume. Now, 45-55, it's not a precise measurement. What it says is exactly what I've just said. A little bit more below, a little bit less above. Now, whether it's 54-46, 53-47, whatever, it doesn't matter. It's just that you have to have a little bit more below than above in order for it to be naturally attractive. Now, the other 2 features, so you've got the skyward pointing nipple, this volume distribution. So we talk about this upper pole slope. So the upper pole slope in a fake boob job, it's a convex curve because you've got a ball there, but that's not natural. So if it's natural, it's a straight line or it's very, very mildly concave. And then the 4th feature, also very important feature, is the tight convex curvature of the lower pole. From the nipple down to the breastfold is a tight convex curve. So if you've got those 4 features, you have pretty much an indisputably attractive natural breast, okay? What we then did as part of the study which we went on to publish is we then asked the question, well, what happens if you deviate from those norms? What if you've got 55-45 or 30-70 or 60-40? What if your nipples point downwards? What if you don't have a nice curvature? And basically, long story short, the more you deviate away from those parameters, the less attractive the breast becomes.
And Pat, who was judging the attractiveness of the breast? Men, women? There were differences, I believe. This is a trilogy, this story. So part 1 was effectively the realization of this concept. And to me, it made immediate sense. It made immediate sense. And one of the things, I'll stop just more for Alison than for you, Adrian, because you're a surgeon. But effectively, what I was saying was something fundamentally opposite to what everybody had been practicing up until then. Because when people talk about breast augmentation, everyone's obsessed with fullness of the upper pole. And I'm telling everybody, no, that's wrong. What you need to do is fill the lower pole, not the upper pole. So,
Do you know that what's really interesting listening to this, and it's obviously coming because my speciality is non-surgical, is what you're describing is lips. So, for example, we know that the lower lip should be 2/3, so the upper lip should be 1/3 smaller than the lower lip. So it's the same sort of thing, and yet people get obsessed with this volume of the upper lip, and the proportions all go wrong. And sometimes you look at it, and I'm sure it's the same, and you think something. Well, an untrained eye would look at that and think, I know it's not quite right, but I don't know why. And that's exactly the same thing. So it's quite interesting that the two very attractive things on a woman that often people focus on, it's the same thing.
Yeah,
very similar. So having sort of identified this concept, which makes total sense to me, in order to sort of verify, because I don't want people to say, oh, you know, that's your opinion, that's what you think, you know, but that's not. So we carried out a population study, which was the biggest study of its kind published. 1,400 individuals, 700 men, 700 women, all ages, all ethnic backgrounds, all social backgrounds. And we took 4 images of profiles of breasts, and we morphed those images into different proportions. And amongst which was the 45-55, and then a whole bunch of other proportions. We basically asked people to score their preferred image and proportion. And again, to cut a long story short, 86% of the population, male, female, you know, whatever ethnic background, whatever social background, will choose the 45-55 as their preferred ratio. And in there we were about 60 plastic surgeons, and 95% of them chose the 45-55 as their preferred, you know, image. And yet I asked myself, how many of them put that into practice? And I suspect not very many. So
could quickly ask you, what were the differences between different ages and the different sexes as judging a beautiful aesthetic?
So I mean, the answer is there were no differences. You know, or there were very, very minor differences. So we looked at a captive age group, women under 40, we looked at women over 40, men. I think two of the most surprising things were men and the ethnic backgrounds. So often there's this idea that, oh yeah, well, this is a Western breast, or, you know, men like this and women like that. And actually, we found that there was virtually no difference in ethnic choice. So whether you're South American, African, Indian, Asian, wherever, you're all choosing the 45-55. It's a very fundamental observation. Yeah.
Also, can I ask, so say do we know how much of the population, okay, say you're naturally born with this 45-55.
Yeah.
Does that stay with you for life? Does it change if you breastfed? Does it change as you go through menopause or anything?
So that's a very good question. So in conclusion of all of this, having done this population study, what is it about this 45? There's obviously something fundamentally and universally attractive about this. And what I think it is it represents, you know, natural beauty in a breast which has been untouched by the forces of nature, such as weight gain, weight loss, gravity, breastfeeding, etc. Because all of those forces do change your breasts. Of course they do. So if you as a young woman are blessed with that beautiful proportion to begin with, there's a very good chance that's not going to last. You know, with aging, pregnancy, weight gain, weight loss, skin quality, etc., etc. But what it becomes is, it becomes a framework, a reference point around which, if you want to produce a naturally attractive breast, you can start to plan around that. And it doesn't matter if you're reducing a breast, lifting a breast, putting an implant in breast, the end goal is always the same, and it's trying to recreate those parameters.
Yeah, so that was brilliant. I mean, so I think, Al, so there's some of the simplest ideas are the best ideas, and that was a pretty simple idea, as we'd expect from you, Pat. But it really was a good idea, and you know, it's really caught on, hasn't it, Pat?
Well, I mean, it's an idea that, you know what it was, as Adrian says, I mean, I didn't just discover anything. I simply described what was sitting in front of everybody. It's that elephant in the room. And, when I started getting invited around the lecture circuit worldwide, most, nearly everybody's reaction is, oh yeah, of course, yeah, of course, yeah, of course, of course we can see that, but it just hadn't been described. It's as simple as that. And actually, it also throws up a whole series of nuances when I talk to patients. And it's very interesting when patients come in, and I'd be interested in Adrian's input as well, because when a woman comes in to talk to you about breast augmentation, she almost never thinks of herself naked. So I distinguish between what I call the clothed look and the naked breast.
Yeah.
And the two don't correspond, because the clothed look is about fullness, cleavage, the way I look in my bikini, the way I look in that dress or in that top. But when you remove that bikini and you've got those two footballs there, you've got two ugly breasts. So the two do not correspond. And these are nuances. It's about unpicking concepts which patients haven't thought about themselves. In fact, most surgeons haven't thought about this. And so when a woman comes in, the first thing she'll say to me, when she's got droopy boobs down here, she'll say, oh, I need a load of volume up here. And I'll say, no, you don't. I said, you need a load of volume down there. And she'll look at me, what are you talking about? And I show all my patients, my lectures, my images, the minute they see the image, oh yeah, of course, yeah, no, of course, yeah, I get it.
But that I think comes from, it's the same sort of is that patients know kind of what they don't want. So they don't want the boob they've got, but they don't really know what they do want. And they don't really know, because they've only generally looked at their own boobs, whereas you and Adrian have obviously looked at lots of boobs. So I think that's part of it.
But again, I think using your analogy with lips, and I think breast augmentation has suffered this as well, is it's this idea that volume per se will give you a nicer breast.
Yeah.
Now, it won't, and you've already talked about this. It's volume distribution, which is what gives you a better breast, not volume alone. Volume alone can give you an uglier breast. It's not good enough just to give volume. It's how you distribute that volume. And I think that's applicable, to the breast, to the lips, to, whatever you do it. So this idea that you're just shoving in some volume to get a better breast, that can't exist anymore.
Yeah, I think you're right, Pat. So you mentioned Leonardo da Vinci, all these artists, they have the facial proportions, the lines, they help you judge what is a beautiful face, don't they, Al? And I think you were the first. The only thing we knew, you were right, there was a guy called Penn that we learned about in our training, didn't we, Pat? And what did he show? The 21 centimetre thing, wasn't it?
Yeah, but you can have a 21 triangle with tuberous breasts.
Yeah, absolutely.
You can have a 21 triangle with pseudototic breasts.
Yeah.
So it's actually a useless measurement.
But his research was what we learned when we were young, and that lasted until your theory, didn't it? Really?
Yeah. It's
quite interesting to leave on it. So you did mention this to me before we came on sort of line, was that your now 45, 55 proportions are part of the training or examination. Is that right?
They appear on the American board exams, as a question in terms of breast aesthetics,
But what I did just say before, Pat, have you written one of those?
Listen, I've written lots of chapters in those, mate.
Have you written a whole one?
That used to be, along with the fairy tales that I used to read to my children when they were younger, that used to come out, Adrian.
For people that are listening, this is Adrian's book that he's just shown us, that he makes. How much do you make from that a year, Adrian?
I think I make £186 a year on average. And I spend it on, but it took me, so it's basically, Pat, what is it? It's a plastic surgery book for dummies, in a way.
Yeah. It's a great piece of work. It's a great piece of work for the trainees. Now, I know, I'm intrigued actually, and I'm going to ask Adrian a question, because we're talking about simple classifications, ideas, and so on, etc., etc. And one of the things that a lot of people will know about when they talk about breast augmentation is about hardening of breasts, what's known as capsular contracture, where you get the scar tissue around the implant. And again, a bit like the Penn's triangle, we have this archaic classification called the Baker classification, which isn't, it's very subjective. It's not particularly, it's not really particularly helpful. And I know that Adrian, you've been sort of redefining this, yeah.
So it was a bit like your 45-55. Basically, we have this classification. We don't even think about it. We just use it. But basically, it's not very good and it's not updated. And we were doing a study of LED lights, Pat, for people that have got capsular contracture. Capsular contracture is when the body forms a scar tissue around the implant and can squeeze it and make it tight. The three things you get, if you get capsular contracture, it becomes firm, it changes shape, and it can become painful. The Baker classification is just 1 to 3 or 1 to 4, isn't it, Pat?
Yeah.
Which is basically 1's normal, 4 is rock hard.
The problem with it, of course, is that what's 2 to me might be 3 to you, might be 1.5 to someone else, might be 4 to some. That's the problem, isn't it?
Yeah. So there's no real effective grading. So in every other type of medicine, Pat, we've got a good grading system. For any medical condition, we've got grading, and we've got the MD codes and everything for non-surgical. So what I developed, Pat, is called the FAP, so the FAP grading system. Okay. So F is for firmness, A is for appearance, and P is for pain, and it's from 1 to 5. Okay, so 1F is basically completely soft, 5F is very hard, appearance 1 is normal, 5 is very distorted and changed because of all the contracture, and P is from 1 no pain, 5 bad pain. So you can say, well, this patient's FAP score is 434. What does that add up to? 11, is it? So yeah, 4, 3, 4, 11. Do you see what I mean? But it tells you which element of the firmness, appearance, and pain is the worst for that patient.
Yeah.
And do you always operate? So if someone gets this sort of, encapsulation, do you always operate, or can it? I'm just thinking of encapsulation that comes with large amounts of certain dermal fillers when they're used. Sometimes you can treat with steroids, antibiotics, yada, yada, yada. Can you with this or not?
Do you want that one, Pat, or do you want me to do that one?
Well, you take that one.
So basically, capsular contraction is when the body walls everything off. So the body walls anything off: a hip replacement, artificial valve, a pacemaker, dermal fillers, anything big enough, the body recognises it's not its own and walls it off. And the wall is the capsule. Okay, so everyone with a breast implant has a capsule, but it's normally soft and you don't feel it. When it goes hard, it can cause those problems we discussed. Some patients don't even know it's gone hard. And new implants that we use, Pat, have a very low risk of capsular contracture. It's not dangerous for the patients, but you can get firmness, appearance changes, and pain. And Pat, how do you decide? It's basically up to the patient.
Yeah, I mean, I think in answer to your question, not everybody with a capsule needs surgery, and they don't need it, there and then. And it really depends on 2 things. Really, is how much pain they're in and how disfiguring it is. Or sometimes it's people don't like the touch, the fact that it's firm, it's harder. But yeah, there isn't a black and white. And I mean, it's the first time I've heard Adrian's classification. What I like about it is that there are those different elements that you can, describe and break it up to. There's still going to be a variation about whether I think, you're a 3 or a 4 in terms of firmness, but there are more elements that you can describe. And I think that's, I like the sound of that. I like it.
Yeah. I think it just gives us a good way of talking. So I could say to you, she's a fat, this patient is a fat 434, whatever. You immediately know a bit more detail than that she's a Baker 2.
Yeah. What may not apply is that you might get a FAP score 10, which doesn't need surgery, but another FAP score 10 that does.
Yes, that's true. But
does that make sense?
Yeah, but it's a good way, you see. If you've got a treatment, so we found that LED light treatment was taking patients down an average of 2 FAP grades.
Right.
So it is improving it a bit. It's not getting rid of it, but it's improving it a little bit. It gave us we developed it as a measurement tool, but it's come. But no one's invited me all around the world talking about it, Pat. I'm like, no.
Adrian, I mean, have you published it?
No.
Well, that's why you've got to publish it.
But you went on to like breakfast TV with it, yours, didn't you?
Well, actually, funny enough, you're absolutely right. And let me tell you the bit of the story I didn't tell you about, which I'd forgotten actually. The 45-55 thing was I gave this lecture it was a one-off breast teaching day at the Royal College of Surgeons, and the media were present. And I don't know why they were present, but they were. And I gave this talk presenting this, you know, my 4 parameters of perfect breast. And I'll never forget this. It was on a Saturday, and it was early summer. And on the Sunday, I was in the park with my kids. Sunday, the day after I presented this talk, and my phone went off. My phone rang. And it was a no caller ID. I picked up the phone, and it was a journalist from the Times. And journalist from the Times said, "Oh, yeah, is that Mr Mallucci? Yeah, Mr Mallucci. Look, you know, we were at your talk yesterday. Amazing, fascinating that you've discovered the formula of the perfect breast." So this guy was on the phone, put the phone down, and it rang again. And this time it was a German newspaper. And, you know, a German guy had got hold and wind of this. I put the phone, and basically, cut a long story short, that whole afternoon and the next 2 or 3 days, my phone did not stop ringing. And the media from all over the world. And I remember driving to work. I don't think even you know this, Adrian. I remember driving to work. I got a text from my brother, who sent me a photograph of a double-page spread in the Sun, and at the top it says "The Professor of Boobology's verdict," and a picture of me. And I remember stopping the car in Regent's Park on my way to work, and I sort of thought, oh my God, this, I sort of panicked. I didn't really know what was happening. I was scared. I was a bit scared by this influx of media attention, which had just come from nowhere. And I remember ringing Tingy Samoes.
Yeah.
You remember Tingy? She was the PR for the Barbs. I said, "Tingy, I'm really scared. I don't know what to do. I gave this lecture on Saturday." I said, "And now I've been bombarded by the world's media, and I don't really know what to do." I kid you not, there was a Belgian newspaper that did a Sunday time, you know, a day in the life of, you know, Patrick Mallucci, and, you know, they wanted to know all about my life, and it was crazy. It was absolutely crazy. And all of this before we'd actually published the work. And that was the other thing which kind of scared me, is because this had been let out the bag before it had been published in black and white. So the race was then on to get this published and peer reviewed. And actually PRS, which is the American journal, declined it. They declined it.
Really?
Yeah, they declined it first time around. And therefore we got it published in the British journal just to get it published. And then PRS published all the subsequent papers. But yeah, no, that was
it was like a sort of a genius idea. You know, like people when they're young have a genius idea and don't even realise they, you know, when a musician writes a brilliant song or something. You know, what does it normally mean, Pat, when you get a no ID number for a plastic surgeon? Like no ID phone calls.
Listen, I wouldn't know. I haven't answered one for so many years, so you know, I wouldn't know.
Plastic surgeons generally don't like no ID phone calls because they often come from hospitals, and if the hospital is ringing you, it's normal. It's not normal.
Oh, it's not that you've saved someone in your address book as no caller ID then.
No, it can do that actually.
So that's quite amazing. Professor of Boobology. Now that leads me nicely on to media. And, you know, Patrick, we do know that, and I want to know particularly, because I don't have such a big celeb following, about the challenges. And this must have then brought you international clients, celebrity clients, and the challenges of treating those, because they now want the perfect boobs.
Yeah, I mean, to be quite honest, listen, you know what, and Adrian will tell you this, and I know it sounds like a bit crass, a bit cliche, but you don't treat, you know, everybody gets treated exactly the same way. You know, this is where as surgeons, we're quite mechanical. You know, there's a job in front of you, you know what you have to try and achieve, and you try and do it to the very best of your ability in every single person who comes in front of you.
Can I just say that, Pat? So I would 100% agree with that. So basically, the best plastic surgeons I've seen are, including Pat, are people who try their absolute best all the time.
100%. And I really, really echo that. And one of the things I tell people is I'm extremely vain about my work. You know, it's a source of pride for me. And, you know, the idea that I would do something badly on somebody would be a great source of shame. You know, if you're going to take your top off and show your friends and they're going to go, oh my God, you know, that's not good for me. I want everybody to go, wow, you know, and so I worry about the outcome more than they do probably.
Yeah.
And that approach is with everybody.
Is it the same in non-surgical, Al?
Yeah, it is, because, well, in fact, possibly more so, because we're dealing with something that's on show. So we're dealing with the face. So every patient that walks out the door is my business card, you know, and I'm really hoping,
Yeah,
I always say, I always say they should look like they don't need anything doing rather than they've had something doing. So it's like a breast, I guess, is, you know, I haven't had mine done, but if I did, I guess I would want them to stay looking very natural. And actually, it really upsets me when I see my two clinics are sort of local clinics, Wimbledon and Wandsworth, so there's sort of more of a sort of village feel about them. There are some people, ladies, walking around the sort of areas that look just ghastly, strange, whatever you want to call it. And it bothers me if people think they might be my clients, because it's not what I stand for. So it's the same thing.
Absolutely, you know, and I think you said it absolutely clearly there, that, you know, they are your business card, you know, and
I think what's different though, what's quite interesting is, so when in non-surgical, so a girlfriend of mine who works in non-surgical, we met on a course years ago, and she's based out in Essex, and she doesn't have Mallucci or Richard's boobs. She has probably your sort of big football boobs, long nails, big lips, yada yada yada. And I was always saying to her, if you ever came and worked in my clinic, it wouldn't work, because clients would take a view and think this isn't for me. And she said vice versa. If you came to Essex, you look like a librarian, no one would want to be treated by you.
Yeah.
But it's different really, because patients do come in, and I know they take a look at me and my team and think, okay, they look how I might want to look, aspirational, you know, they look quite normal and all of that. And so they do it, but that's different for women when they come into you. So you really are, I guess, relying on your before and after photographs, because they can't come in and look at you and think, yeah, I want boobs like that.
No.
Yeah, it is interesting. And I think Adrian will say that. I think one of the things that is true is that, you know, as individuals, and I think it's probably exactly the same for you in non-surgical, I think we all attract our own population of patients. Yeah. So, you know, the 19-year-old who wants to look like a porn star doesn't come to me. You know, she doesn't come to me. I don't see those patients. I don't see people who want, you know, 750cc boobs. They just don't come to me. So you tend to create, you know, a following, you know, a clientele who buy into you and what you do. You know, and it's not to say that what I do is better than what someone else does. It's what I do. And do you agree with that, Adrian?
And I would, yeah, I'd absolutely agree. And you don't even do it knowingly.
No, absolutely, 100%, absolutely.
Yeah, and the other thing I would like to say, I know Pat understands this, is we talked about this before. There's a perception that these people are all vain. They want big breasts. Now, a lot of mine and Pat's patients are people with asymmetries. So one breast hasn't formed, tubular or tuberous breast. You know, I often amazed, I think you see this as well, Pat. So someone comes in, externally they look brilliant, you know, but they seem a bit stressed about something. They won't show you. They say, you're the first man who's ever seen my chest.
Yeah, absolutely.
You get this, yeah. And when they show you, I mean, they do have a problem.
Yeah, absolutely.
They're not making it up, are they, Pat?
No, and so you're right. I mean, we're really getting into the territory of where, breast augmentation tends to, be put under one, umbrella as just wanting to be, that's what. But as Adrian says, actually, it can be extremely challenging. There's all sorts of different anatomy out there. And a lot of it is about just wanting to look a little bit more normal, inverted commas, just to restore a bit of confidence and a bit of self-esteem. That's a very large part of what we do.
And
I think you're right, and I think it's misunderstood a lot that people do make an assumption. The same coming into aesthetics and things. And I think when we go back to our patients, and this is why our practices are successful that we run, is because you're absolutely right, Patrick, is that, when people say, do you ever have patients you don't like or don't go? No, because the reality is patients come because they get a feeling for us, a trust for us, and all of those things. And it has to be mutual, because if the patient doesn't feel that, then you're not going to feel like you can operate or inject or whatever.
Yeah,
absolutely.
I would just say, so I know you agree, Pat, that a lot of these patients are not people having a lot of plastic surgery. They've got one main problem. It's causing them lack of self-esteem. They get it.
Absolutely. Yeah.
They're not the perception of people, of having lots and lots of plastic surgery.
No.
So we probably need to move on a little bit, because we haven't covered your clinic, we haven't covered your international travel, and we haven't covered your life outside plastic surgery. So which one do you want to start with?
You choose.
Alison?
Let's go with your clinic. So we've talked a lot about boobs, Patrick, but obviously I've had a browse of your website this afternoon, and boobs aren't the only thing. So what else is it that you're doing?
Yeah, I mean, so interesting. Just a little bit of history about my clinic. It's funny because I do a lot of international traveling, a lot of lecturing, a lot of teaching, and I do quite a lot in America. So I have very, very close friends in the States, and I'm sort of very much able to sort of watch and follow what they do, etc. And I suppose the clinic is quite a sort of a US style or a US concept clinic, where a surgeon will base a non-surgical facility and family around him, and so you have a merging of surgical and a marrying of the two things together, and it makes sense for lots of reasons. It makes sense for business reasons. It makes sense for continuity of care. It makes sense for alternative treatment and cares, and there really are alternatives. And I think as I learned and I watched others, it just made an awful lot of sense to me. And I looked at London and I thought, this doesn't really exist in London. People haven't really done this yet. And I know there are people like yourself, Alison, and lots of. But I'm talking about plastic surgeons who've taken it on themselves to add this onto what they do. We're brought up as surgeons. Surgery is surgery. Non-surgical, off you go somewhere else. So I became very interested in combining the two. And I have to say that it's made, I love it. It's added a huge element to daily practice. There are so many times when I'll see a patient, I'll think, you know what, I'm not sure whether surgery is the right thing here, but we've got lots of other modalities here. We've got, cool sculpting, M-sculpting, radio frequency. Why don't you go and speak to, one of our nurses and see? Because I think, actually, rather than the knife and downtime and generalism, actually, you might benefit from that. That might be the answer for you. Or maybe we combine the two. And so, this idea of marrying the two just made so much sense. It's made me learn an awful lot and to disengage from this very rigid, I'm a surgeon, all I care about is surgery, I'm not really interested in anything else, which is, I think Adrian would agree, quite a sort of a British upbringing in terms of surgery.
I would agree. I think with the greatest will in the world, a lot of plastic surgeons are not that interesting, Pat.
Yeah, absolutely.
Uh,
But
I mean,
when
they're very
you
good
look,
at their job, but they make. I
yeah,
mean, maybe you don't want plastic surgeons to be interesting, but
but
you know.
when you look to the United States, when you look to Europe, when you look to, you know, just offering the best, you know, available options, everything for your patients, you know, if you're just doing surgery, you know, you're missing out on an awful
Yeah.
lot.
Yeah, and I think that's a lot. I mean, on our courses, we take people. So basically, medical people have been trained very well medically in that niche, like a musician. You know, they've done their 10,000 hours. That's what they've done. If you ask the average plastic surgeon, Pat, you know, about anything outside, they're not very good at general knowledge quizzes.
No.
Because they're so.
Yeah, it's not that. Well, I think it is that, but I think it's also. But that's the difference for a lot of people. I think it's the fact that during your medical training, at no point do you have business training or business acumen. And I also think it's very hard. And I see it in nurses quite a lot. That I feel very lucky. So when I left the NHS, I then had 10 years in a commercial role, totally left sort of medical practice. And I think that's why I've had no issue with coming now back into aesthetics and sort of saying, I'm okay with valuing my time and this is the cost for my time and da da da. But a lot of people, when they first branch out from the NHS, they really struggle with that. So then to ask them to set up a proper commercial business and also to think about ancillary structures around them like you have, that means that, because I think what we need to create, and this is what you've done, Patrick, and this is what sort of I've done, I guess, from a non-surgical point of view, and Adrian, you do it with breasts, is that I would never like to think that I would have to refer a patient somewhere else if it's something that we could deliver properly. Now, I can't do boobs, so I guess I need to refer this, but I don't want to think that there's a better option out there that can be delivered non-surgically that I can't offer the patient.
Yeah, and there are limits to what you can offer. So tell us actually where the clinic is and what it looks like.
So the clinic is in South Kensington. How can I describe the clinic? We've deliberately made it not too clinical in its appearance. It's not white walls and white. It has a modern feel to it. It's got quite a luxury feel to it. It's almost
got a bar in it.
It's got a bar. It's got a marble bar in it.
Yeah.
It's almost a slight sort of, you know, boutique hotel-y sort of type feel to it, maybe. It's got a little bit of urban touch, you know, exposed brickwork and iron framework. It's a cool environment. You know, it
sounds like Sanderson. Sounds like Sanderson in San Francisco. It's got a bar. I'm popping by.
It's Alison, you are welcome to join us for a little glass of prosecco at the end of the working day. You drop by.
And so it's a beautiful place. It's got the 55-45, isn't it?
It does. It has a little sculpture on it. Yeah.
And remind us what it's called, Patrick Mallucci.
The clinic's called Malluci London. Yeah.
And it's not just you. You have other surgeons. You know, it's a whole.
Yeah, it's not just me. I have a surgical associate. We have nurse practitioners. We have other beauty therapists who all of whom sort of provide their bits of expertise. And as I said, for me, that's been the real fun is putting that together. And also just the understanding that, you know, technology really has moved on. It gets better and better. You know, the whole, you know, even injectables, the whole skin booster generation, everything changes. It's very exciting. And Alison, you'll know better than anybody, you know, the results you can achieve, you know, are astonishing. You know, people like yourself who are good at what they do, experts in the field, can really transform people, you know, through, you know, relatively non-invasive techniques. And so...
Yeah. But also I was going to say, I'm sure some of the things, like you were just talking about skin boost and needling and all of those kind of things, they can be then transferred into your body treatments. So when you're rejuvenating breasts and all that kind of thing, so it will be transferred across.
Yeah, absolutely. And that's what's really enjoyable is trying to say, right, how can we marry these together? What can we get more? And that's really taking me in a different, you know, direction.
Yeah.
I was just about to say, on that note, marrying treatments together. Come on, Patrick, break the ladies of London's hearts. Are you married? And tell us about your family situation.
I am married. I am married. My wife is Greek. We have 2 children. My daughter is 17. My son is 19. None of them are going to be medics, which is fine by me. I'm delighted. We're all medics in my family.
Tell us about, Pat, just tell us about your brother and your sister.
Yeah, so I'm the dunce. My sister is a professor of neuroscience at Cambridge, and my brother is a professor of pediatric neurosurgery at Alder Hey. So as I said, every family has a black sheep. You have him in your presence today. And
your heritage, Pat, you're half Irish, half Italian.
Yes, my father is Italian, my mother is Irish. We brought up bilingually. We've always spoken Italian at home. My father didn't really speak very much English when he came to England. And my mother actually had moved to Italy. She was working and living in Italy at the time. So that was really the family language and the way it's remained.
I know you treat a lot of very famous celebrity people. How do you deal with that? I've talked to you, about not the exact cases, but some of the situations you've had. We talk privately. So, any thoughts on that before we?
Yeah, I mean, as I said, I mean, I think the best, I honestly don't treat them any differently to how I treat anybody. I think, we all know that expectations are extremely high. In many ways,
it's normal to be interviewed by bodyguards first before you meet the patient.
I could tell you a story about that, about a particular celebrity some years ago, but I won't. But that has happened.
Yeah. So you're vetted by the bodyguards.
Yeah.
Before you're allowed near the individual.
That has actually happened to me. Yeah.
And you had to fly over to visit the person, didn't you?
Yeah, I've done that. I've done that a couple of times as well. Yep, been flown out to see various people. Yeah.
Yep. So Al, anything you'd like to add before we bid adios?
No, I think it's been brilliant. I think it's funny. Obviously, knowing your heritage now, half Irish, half Italian, I love the fact you're called Patrick Mallucci. Kind of says it on the tin, doesn't it?
It does, yeah.
Kind of says it on the tin.
Anyway, guys, you can't have too many ski holidays, can you? So guys, thank you. Al, thank you. Big thank you to our Irish, Italian plastic surgeon, who is Mr. 5545, Mr. Mallucci. Bye.
Thank you very much for having me. Bye.